A 51-year-old male presented with chronic headaches. I am showing you a lateral skull radiograph and a sagittal T1 weighted brain MRI. Describe the findings.
Okay, looking at the images, the lateral skull radiograph shows elongation of the jaw or prognathism, frontal bossing, marked thickening of the calvaria, and enlargement of the frontal sinuses. In addition, there is pronounced enlargement of the pituitary fossa, which appears expanded but demonstrates no osseous erosion. The sagittal T1 weighted MRI confirms the calvarial thickening and frontal sinus expansion and reveals a large, soft tissue mass lesion within the pituitary fossa. This pituitary mass is highly consistent with a pituitary macroadenoma. There is also clear evidence of macroglossia, or tongue enlargement, on this MRI scan.
I am showing you 3 more radiographs for this patient. What do they demonstrate, and what is the diagnosis?
The magnified plain skull radiograph demonstrates marked expansion of the sella turcica, which measures greater than 15 millimeters in length. The radiograph of the hand shows prominent soft tissue enlargement, giving it a spade-like appearance, along with widening of the terminal tufts of the phalanges. The lateral soft tissue radiograph of the foot demonstrates marked thickening of the heel pad, measuring well over 25 millimeters. These findings are diagnostic of acromegaly, secondary to a growth hormone-secreting pituitary macroadenoma.
Explain the pathophysiology, typical patient demographics, and other musculoskeletal features of this condition.
In that case, acromegaly is caused by excessive secretion of growth hormone by the anterior pituitary gland, usually after growth plate fusion. This condition typically presents in the 4th and 5th decades of life, affecting males and females equally. Musculoskeletal features include mandibular hypertrophy, supraorbital ridge prominence, dural ectasia, and posterior vertebral body scalloping. Patients also frequently develop premature osteoarthritis, particularly in the large weight-bearing joints and spine, with prominent osteophytes. In children, growth hormone excess before epiphyseal fusion results in pituitary gigantism rather than acromegaly.
What are the potential systemic complications of this disease?
Well, systemic complications include cardiovascular disease, such as biventricular hypertrophy, hypertension, and congestive heart failure. Metabolic complications are common, particularly impaired glucose tolerance and diabetes mellitus due to growth hormones' anti-insulin effects. There is also an increased risk of colonic neoplasia, necessitating regular colonoscopy screening. Mass effect from the pituitary macroadenoma can compress the optic chiasm, leading to bitemporal hemianopia.
What are the medical and surgical management options, and how would you manage this patient as a radiologist?
Okay. Medical management options include somatostatin analogs to suppress growth hormone secretion, or dopamine agonists like bromocriptine. Surgical management is typically transsphenoidal hypophysectomy for mass resection. As a radiologist, I would recommend a dedicated pituitary MRI protocol with dynamic contrast-enhanced sequences to define tumor boundaries. I would also recommend screening for systemic complications, including echocardiography and screening colonoscopy, and prompt neurosurgical referral.